God. Uy, good afternoon. Ikaw na mag-introduction.
Ano to kasi?
Good afternoon.
Okay, good afternoon, doctors. Today we will have our third case presentation for this sub-rotation in the wards, pediatric wards. So, this is a case of patient HBM. Unfortunately, we were not able to personally interview the patient's parents, as the patient was a private patient admitted and was discharged on the day that we were supposed to interview the parents. Okay, so the patient is a full-term male with a birth weight of 3,060 grams, delivered via repeat cesarean section with noted good Apgar score, a Filipino Roman Catholic from Fairview. So, the chief complaint was jaundice. So, upon birth, the patient was discharged. Jaundice, noted to be secondary to a physiologic cause. So, an exposure was advised. However, the patient's parents had poor compliance. At 4 to 5 days of life, patient was noted to have poor suck and activity and had increasing intensity of the jaundice. Patient was then brought to the medical city where labs were requested, revealing a total bilirubin of 45 milligrams per deciliter. Hence, the patient was advised admission. Unfortunately, we were not able to get hold of the admitting notes and the patient's full course at the medical city. Hence, we will just proceed with what we have. So, we were able to gather some laboratories, including the MRI of the brain, which showed symmetric hyperintensity of the globus pallidus on T1 with no evidence of mass, acute infection, or hemorrhage. Cranial ultrasound was noted to be normal. For the past medical maternal history, the mother has no known allergies, previous surgeries, or illnesses. The mother is a then 35-year-old gravid 2 para 11001, pregnancy uterine at 38 weeks age of gestation, cephalic, not in labor. When she was admitted, she had regular prenatal consults each trimester with no noted maternal illnesses. The first pregnancy was in 2013, delivered via cesarean section due to cephalopelvic disproportion to a female newborn at the medical city with unrecalled birth weight and no noted fetal-maternal complications. Family history is negative for asthma, hypertension, diabetes, and the previous sibling had no jaundice upon birth. For nutritional history, patient is exclusively breastfed. Personal and social, the patient lives with his parents and older sister. He has a nanny who takes care of him, and both parents work, but the mother is now the primary caregiver. For the review of systems, this essentially unremarkable apart from the skin, which presented with generalized jaundice up to the lower extremities on the second day of life. Upon physical examination at the time of admission, at the 4th to 5th day of life, the patient was awake, irritable, with poor suck and poor activity, with generalized jaundice as mentioned, with icteric sclera. Other organ systems were unremarkable. So for the salient features, we have a male infant born term via repeat cesarean section with no fetal-maternal complications, but developed generalized jaundice on the second day of life, with a total bilirubin of 42 milligrams per deciliter, noted to have poor suck and activity, with hyperintensity of the globus pallidus as seen on MRI. Okay, so our case is on jaundice. We focus on jaundice. So when we talk about jaundice, we should review our bilirubin metabolism. So for our senior interns, this is a review of the chemistry of bilirubin metabolism. Okay, so bilirubin metabolism begins with the life cycle of RBCs, which have a lifespan of around 120 days. After this span of time, the red blood cells are broken down into its components via the liver and spleen into hemoglobin. Hemoglobin releases its components such as the heme and globin. Globin in turn is broken down into amino acids and utilized by the body. Heme, on the other hand, is further broken down into iron and biliverdin. Okay, so biliverdin is then converted into unconjugated bilirubin. Since this unconjugated bilirubin is not water soluble, it needs albumin to be transported into the liver for it to be conjugated. So in the liver, it enters the biliary system and is then conjugated via the glucuronic acid, wherein the bilirubin now becomes conjugated and water soluble. And then it is processed into the small intestines via the normal flora into urobilinogen and stercobilinogen. And then this is bilirubin is now transformed into stercobilin, which is excreted into the feces. About 10 to 15% of bilirubin is transported into the blood, which enters the enterohepatic circulation, and some of them are also transported into the kidneys and processed as urobilin. Okay, so that's the review of our bilirubin. So this will be helpful in our differential diagnosis. Next slide, please. Next slide. Okay. So, our main pivot point in this case is neonatal hyperbilirubinemia. Hyperbilirubinemia refers to the imbalance of bilirubin production and elimination, as was discussed earlier. In order for bilirubin to be cleared from the body, it needs to be conjugated in the liver, excreted in the bile, or eliminated via urine and stool. Hyperbilirubinemia is the most common reason why neonates get admitted, since unconjugated bilirubin is neurotoxic. So this slide just shows us the basic differences between the following terms. Jaundice refers to the deposition of bilirubin in the skin and mucous membranes. When unconjugated bilirubin deposits in the brain, this is now called acute bilirubin encephalopathy. And when there is further increase in unconjugated bilirubin, such as there is now permanent neuronal damage, this condition is now called Kernicterus. So, in newborns, total bilirubin exceeding 5 to 6 milligrams presents as jaundice, as compared to older children and adults, wherein bilirubin usually manifests at only around more than 2 milligrams per deciliter of total bilirubin. So, the jaundice usually spreads from the head to the toes, and visual assessment is usually subjective and needs usually experienced by the observer. So in diagnosing hyperbilirubinemia, we should have a careful clinical assessment, thorough history including pregnancy and delivery, general health status, and infectious risk, feeding method and feeding progress, vital signs input and output, risk factors for isoimmunization including blood types of both parents, and family history and ethnicity. For the physical exam, should take note of the activity level, feeding ability, bruising, or hematoma. So, the following are the risk factors in having severe hyperbilirubinemia. Jaundice in the first 24 hours of life, visible jaundice before discharge, previous jaundice sibling, gestational age of 35 to 38 weeks, Male sex, maternal age of 25, at least 25 years old, losing cecal hematoma, exclusive breastfeeding, and East Asian race. So among these factors, our patient presented with visible jaundice upon this, before discharge, with a gestation of 38 weeks, a maternal age of more than 25, and exclusive breastfeeding.